The Thessaly test to test for meniscal pathology. So I'm going to have the patient stand on her involved side, one leg. Go ahead and bend down to 20 degrees for me. Hold my hands. And we're going to rotate back and forth 3 times. And we're looking for provocation of the patient's pain. Good. Check for internal decapitation. So I'm going to palpate for C2. Place my finger right on the spinous process. And I'm going to posteriorly translate the skull. Anterior drawer. Test for ACL pathology. I'm going to sit on the patient's foot and anteriorly translate her tibia. Palpating at the joint line. And I'm going to compare to her uninvolved side too. This is the single leg hop test to help determine return to sport activity after ACL injury. I'm going to have the patient stand on one leg and hop 3 times, planting themselves on the third, and then comparing sides. Good.
I'm going to, if I localize this here.
Good. And you're going to measure the distance of both of those. Compare. To assess for IT tightness, have the patient side lie. Going to passively extend her hip to about neutral or a little beyond, and then adduct. I'm assessing for tightness. Right about there.
The Ottawa ankle rules. The first part of this is you want to be able to know if the patient was able to bear weight immediately after the injury or in the emergency room. 4 steps. Then you're going to come down to the distal 6 centimeters of the fibula and the tibia and just palpate for tenderness on either side. From there you palpate the base of the 5th metatarsal and then go to the navicular and you're just assessing for any bony tenderness, and that's indicative of radiographs. For the next one, we're going to move to the shoulder and do the full thickness tear. So I'm going to have the patient go into full active abduction, and we're just assessing for any pain along here, the painful arc. The next one out of the 3 is the infraspinatus. So I'm going to have the patient flex to 90, and I'm going to assess the integrity of her infraspinatus, having her resist me here. Then the third one is the drop sign. So have her come up, and then as she comes down, I'm looking for any drop in her and going down. The next one is the acromial impingement. So you're going to assess for the full painful arc again. Good. Then the infraspinatus test again. And I'm also looking to see if her arm deviates inward, which would mean compromising the infraspinatus as well. Then I'm going to do Hawkins-Kennedy. So you flex her to 90, internal rotation, and I'm supplying a downward force, trying to jam the acromial space. And pain is a positive sign of that. It's really good right now. The next order of business, we're going to assess if the patient is a candidate for spinal manipulation. There's 5 criterion that we need to assess. We need to make sure that it's an acute injury, less than 16 days. We're going to want to see her FABQ scale, work subscale. If that's 18 or less, then that's also part of it. We're going to check her internal rotation at her hips. And we want at least 35 degrees in one of the hips. We're also going to check for hypomobility in the lumbar spine. So I'm going to find her PSIS, come over to L5, and do a posterior to anterior mobilization, and move up. And I'm assessing segment to segment, and just assessing for pain or hypomobility. And the last part of the test item cluster is making sure that there's no symptoms distal to the knee. And that would indicate that she is a candidate for spinal manipulation.
Go.
To determine if the patient is a candidate for spinal stabilization, we're going to want to make sure that her age is less than 40. We're going to assess for her straight leg raise on both sides. And we're looking for an average straight leg raise of 91 or more, which she has already. And I'm going to have the patient turn over onto her stomach. And again, I'm going to assess the integrity of her lumbar spine, palpating. And I'm assessing for any hypermobility. All the way up. Good. Now I'm going to have her drop her feet off the end of the table, or her legs. Scoot on down. And I'm going to assess for that same exact spot if there was pain. Get right over top of it, make sure that that's the pain that she's reporting. And I'm going to have her lift her legs up off the ground to stabilize the area. So go ahead. And I'm going to apply that same posterior to anterior motion to see if the pain diminished or if it didn't change or whatever the results are. Go. We are also assessing for any aberrant motion with this test item cluster as well. Test item cluster for cervical radiculopathy, we're going to assess 4 things. One, we're going to take the side that she's having the symptoms on, and we are going to assess for cervical rotation. So what I'm going to do is assess to make sure that she has less than 60 degrees. So go ahead and turn. Okay, good. Then we're going to do the Sperling's test, which we're going to have them laterally flex their head to the same ipsilateral side. I'm going to apply a downward force up to 15 pounds. Also, distraction. I'll lift up under skull. Should alleviate her symptoms. Then I'm going to have her lay supine. And we're going to do an upper limb tension test. And that is the 4th one.
Test.
You always thought I cracked you.
Test item cluster for patients with cervical pain that will benefit from thoracic manipulation. The test item cluster includes symptoms less than 30 days, no symptoms distal to the shoulder. Cervical extension is going to be less than 30 degrees. Also, she's not going to have pain when she looks up. An FABQ activity subscale of less than 12. And also, you're going to look for a diminished thoracic spine kyphosis. This is a squeeze test to determine if the Achilles tendon is torn. I think I'm going to have you...
It's this big.
She's recorded. So,
Maybe it's over that.
Alright. This is the elbow extension test to determine if there's a fracture in the elbow complex. Have the patient raise their arm up, tuck it to 90, and just have them actively extend their elbow. Good. This test is to help determine a high ankle sprain. What I'm going to do is compress here at the tibia-fibula complex. And if the patient's symptoms go away when I compress and then return when I relax, it's positive.